Good afternoon, everyone. I would like to welcome you to today's echo session. And in today's session, we will be discussing quality assurance in HIV testing. And you should agree with me that this actually affects the quality of the whole program. And to help us discuss is Dr. Nancy Zyongwe, who will be making it to the hub very soon. But in that case, we shall be starting with the case which is coming from Western Province and will be shared by a nurse mentor who is Dallas Ndidilwa. With me here in the hub, I have got HNP students and other experts, Dr. Thomas, Davis, and other people, and Mpanji as well, who is coming from the laboratory side. Yes, and Chatonda, who is an expert in IT and ensuring that we remain connected throughout the network. I am aware that we also have a group of mentors who are meeting here in Lusaka, and I think they are in IBEX and they are going through a refresher course together with the new mentors. I welcome everyone and I encourage everyone to participate as we deliberate in today's echo sessions. So we shall definitely start with the case. So Dallas and group, please take over. Okay, so before Dallas, you may come in. We slight omission, sorry. We are supposed to do the recap of last week's discussion, and to help us is Priscilla.
Last week's echo session was on retention in HIV care. It was emphasized that treatment, adherence, and retention are essential to achieve and maintain viral suppression and ultimately reduce or eliminate disease transmission. Retention-related definitions were discussed, which included retention in care, late or missed visits, loss to follow-up, defaulter, unknown status, and clinical contact. Follow-up and tracking of patients is a daily activity in ART clinic. Therefore, facilities need to have a champion for tracking and tracing activities. Pitfalls in the patient's tracking process was discussed, which included missing or incorrect client location information, high rates of unknowns, resources for tracing process, and data management problems. Therefore, there is need to streamline data management system, and facilities should have tools to document the process of follow-up. Thank you.
Thank you very much, Priscilla, for that concise recap of what we discussed last week. Before we start today's session, I would like to remind everyone to kindly observe the etiquette. If you are using your personal gadget, please do not move or try to be stationary. If not, you cannot be stationary. Kindly ensure that you remove the video so as to reduce the number of distractions that we have. So Dallas and the team from Sesheke, are you there?
Yes, we are there, John.
All right, be ready. We are going to share the case. So you can go ahead.
Okay, we are presenting a case from Sesheke Urban, and I'm Dallas, the next mentor presenting. Can go this slide. So it's the case of a 2-year-old male born on 4th April 2017 to a 24-year-old mother who tested HIV positive in 2017. Then at 6 weeks old, DBS was collected and which was taken to PCR lab and the results were negative. Then at 6 months old, DBS was collected, results received 5 months later, which were positive. And at 9 months old, that is before the receipt of before we received the DBS results, the rapid test was done, which were reactive, and the child was initiated on treatment, which was ABC, 3TC, and Lopinavir. Then DBS was done at the time of starting session, which was positive. At 1 year and 10 months, the child was admitted at Center Hospital, and the rapid test was done, which was non-reactive. So after discharge, the mother came to the facility, which is the Sheikh Urban, wanting to stop the child from receiving treatment. Then on 28 May 2019, DBS was collected. Result was received 2 weeks later, and it was positive. So the PCR lab indicated a false positive and had requested for a new DBS sample. Fortunately or unfortunately, we explained to the PCR lab staff that the child actually was already on treatment. So the physical examinations of the baby, height is 71 centimeters, weight 13 kgs, BMI 25.8, temperature is 36.5 degrees Celsius, pulse 102, respiration is 22. So the test that was done at the hospital, which is the Yeta Hospital, was done by a qualified cashier. Next slide. Next slide. Okay, so those are the clinical timeline and lab results as just indicated in the history that we just gave. So DBS was collected for on the first DBS was collected on 12th May 2017, and results received on 16th August 2017, which were negative. Then DBS, again, the second DBS was done at on 6th November 2017, and we received the results on 27th April 2018, and the results were positive. So at this time, we initiated the child on treatment. Then the rapid test of HIV was done on 23rd January 2018, which was positive, and at the same time, we collected DBS, of which we received the results on 10th May 2018, and the results were positive. So the child just continued on treatment. Then on the 15th February 2019, a rapid test was done, which was negative, and the child continued on treatment. And on 28 May 2019, we collected the DBS, and the results came back on we received the results on 11th May 2019, which were positive. So the child continued on treatment. We had a viral load which we collected on 29th November 2018, and it was 476. And then also we collected on 23rd March 2019, and the result were 474. So the child continued on treatment. The HB was sick, which was done on 16th August 2019. It was 12.8 millimoles per deciliter. Next slide, please. Okay, so the CD form, which was collected on the 23rd March 2019, and received the results on the 24th March 2019, it was 600. And the CD4 percentage, which we collected on the 23rd March 2019, we received the following day on 24th March 2019, and it was 27%. So our questions now, next slide. So the mother has been saying she wants to stop the child from taking treatment because she thinks the child is negative. So our first question is, what advice can we give to the mother? And the second question was it necessary to recollect the DBS after rapid test, of which we had already previous 2 positive DBSs? Thank you.
All right, thank you very much, Dallas and team. And I'll just go ahead and summarize the case for today. And just be ready, Dallas and team, to answer any clarifications from the network. So this is a 2-year-old male child who was born in 2017, in April 2017, to a 24-year-old single mother who tested HIV positive. At the age of 6 weeks, a DBS PCR was done and it was negative. At 6 months, DBS was collected again and the result was only received 5 months later. That was at the age of 9 months. Now, before the results for the DBS could be received by the facility, this child had a rapid HIV diagnostic test, which came out positive, and the child was initiated on ART for ABC3TC and boosted lopinavir. Later on, they found that the DBS was positive. Then at 1 year, 10 months, the child was admitted at Yeta Hospital and a rapid HIV test was done and it was found to be non-reactive. So the mother now went to the facility where the ART was initiated with a negative result that the child needs to stop treatment because the child tested negative at the hospital. In May of this year, DBS was collected again, and the result was received 2 weeks later, and it was found to be positive, and the staff explained to the mother. So the questions for today, and we've seen that the timelines for the testing, the viral load for the mother was non-detectable. That was in 2017, although this was after the child was born. We don't know what happened during pregnancy. And the child, first had a DBS which was negative, then it became positive. The rapid test was positive, then it came out negative, and all that confusion. But if you look at the viral load for the child, it's actually less than 1,000 at 476. And in 2018, and then this year it was 474, which is less than 1,000. So the questions that Sesheke has is, what advice can we give to this mother about these confusing results? And then the other one is, was it necessary to collect or recollect the DBS after the rapid test which came out negative when they already had 2 previous DBS which were positive? So this is about resources and all that. So I now invite clarifications and questions from the network or any contributions regarding this case and the questions that they have from Sesheke. I've seen, is it Lucky Lungu? Is that a hand? Please go ahead.
No.
Not a hand.
No.
All
I'll
right,
join it.
Okay, thank you. So anyone who is ready to give us any thoughts about this case, or if at all we have got any clarifications to make. Is it confusing? Or we're having network issues? The network is too quiet. St. Francis, I can see so many people there, so I'm sure they have got something to say. But meanwhile, Nathan can actually give us his contribution. Nathan, please go ahead.
Thank you very much. That was a very good presentation. I'd just like to find out as to how long was prophylaxis given to the child. I understand that from the presentation, the mother viral load was undetectable. I'm sure they were trying to find out to ascertain as to for how long the child would have been given prophylaxis. So I just wanted to find out for how long did they give the child prophylaxis after birth. Thank you.
Okay, thank you very much, Nathan. Dallas and Tim, would you please speak up? How long did the child receive prophylaxis after being born to this HIV positive mother?
Actually, the mother had refused to do anything to the child by then. Even actually, it was tested during pregnancy and antenatal, but she refused to have anything done to her concerning a treatment to end prophylaxis. So the child was not given any prophylaxis at that time.
Okay, I noticed, did this mother also refuse treatment? Because I noticed that the start date for ART in the mother is after the child was born. Did she also refuse the treatment in pregnancy?
Yes.
All right, thank you very much. I hope that is clear for
yes,
Nathan. So this mother refused to start ART in pregnancy and also refused to have anything done on the baby immediately the child was born. I have seen a hand from fast mentors. I just pray that we don't have slow mentors, because that's going to be fast mentors. Go ahead.
Good afternoon.
Yes, and please identify yourself.
My contribution is that the first question,
would you
I think
identify yourself?
Is that the child should continue treatment. Maybe we should focus on quality issues on the testing at the facility. That's my contribution.
Okay, although we don't know you, you could have introduced yourself, but it's fine. Okay, so the first mentors are actually asking us to focus on the quality issues when it comes to testing in this child. Definitely, this is the topic for the day, and we shall dwell on that a little later. So are there any more clarifications for the case for Dallas? Yes, Dr. Thomas.
I just want to know for how long. Hello, good afternoon. I just want to find out for how long was the child breastfed?
Okay, Dallas? Dallas and team, how long was the child breastfed?
The child was breastfed since the time he was born until up to 2 years. The child continued breastfeeding from the time he was born until 2 years old.
All right, thank you very much. Dr. Thomas has another question for you.
Yeah. It's not a question, I think it's a contribution. This child was started on ARVs when the child was 9 months old. And then we did a rapid test about 13 months after the ARVs. We are not supposed to do a rapid test at that time because the child is already on ARVs and the viral load will be well suppressed, and then you won't find the antibodies. That was a miscalculation for that testing. Because the child is already on drugs for 13 months. We don't expect the antibody to be positive. That's why we even don't advise any antibody test in a child who is on drugs for a long time to suppress the viral load. And this child, the first PCR at 6 weeks was positive. Then again at 6 months, it was positive, and the child was started on drugs. That's the right thing to do. And to do the rapid test at 13 months on ARVs, we are not supposed to do that. And even in our guideline, we removed that, but in the old guideline, we used to do a rapid test at 1 year. But due to this reason, we don't even advocate a rapid test on somebody who is on ARVs, which was started in good time.
Okay, so Dr. Thomas, what you're trying to say that a rapid test at 1 year is discouraged now because of the issues of, having... It
will be negative because the child is already on drugs for a long time, so the virus is well suppressed and there won't be any antibodies. So it will give us a false negative result, creating confusion like this to the mother.
All right, thank you very much. Willard is trying to find out was there any confirmatory tests done at the time the child tested HIV negative? Dallas, this is for you. It's coming from the network, from Willard.
Yeah, okay. At this time when they did a rapid test at 9 months, the child, the time they did the rapid test which came out negative, the child was admitted from a different facility and the mother didn't disclose or didn't tell the staff actually to say the child was already on treatment. So they just did the test and it came out negative.
Okay, so there was no confirmatory test for that. What about herself? Did she disclose?
No, she didn't.
Okay, so there we have it. Yeta Hospital went ahead to do a test because the mother did not disclose that this child was already on ART. Any other clarification? Yes, another question from the hub. Go ahead.
Are we supposed to use a rapid test in a baby who is 18 months old?
Dr. Thomas, any help? The use of a rapid HIV test in a child 18 years and above. 18 months, sorry.
18 months and above. First screening is by rapid test, and if it comes positive, then we do the PCR.
So in short, yes, we are supposed to do.
In a baby who is 18
months. Yes.
18 months, yeah.
What about below 18 months?
Up to 9 months, it's PCR. That is the first test. After that, is the rapid test, the screening. If it becomes positive, we do PCR as the confirmatory.
What about the mother's antibodies? Are they not? For how long do you expect the mother's antibodies to be in the baby's blood?
So before that, we thought by 18 months it disappears completely, but there's a small percentage where the maternal antibody can persist up to 24 months. That's when we changed the guideline. We have to still do a PCR when the baby is 24 months and less.
Yes. Yes.
Okay, so just to summarize the answer to the question. So as Dr. Thomas has said, from birth to about 9 months, we're supposed to do PCR. And then anytime after that, up to 24 months, you're supposed to do a rapid test. Now, any positive rapid test result should be confirmed by the PCR. So those are what we have in the guidelines. Anything below 24 months that is positive, where a rapid test is concerned from 9 months, from above 9 months, should be confirmed by the PCR.
Okay, thank you very much. I hope that is clear. I'll now give chance to the mentors who are meeting in Lusaka, and I've seen they have raised their hand. So kindly introduce yourself, the person who will be talking. So you can go ahead. Mentors orientation, please.
Dr. Mpeta, thank you so much for giving us an opportunity to also say something and ask some questions. So there was a concern here that one of the mentors wanted to ask, but I think the question was answered along the way when Dr. Thomas explained. I think that's where our concern was. So far at the moment, we are okay. We'll come in when we have some questions. Thanks.
All right, thank you very much. You may drop your hand now. So let's try to now help Sesheke. What advice can you give this mother? You know, I think we have got a lot of issues in the mother. First of all, this is the mother who refused to do testing in pregnancy. This is the mother, after discovering that she's HIV positive, did not want prophylaxis for the baby, went on to breastfeed for 2 years, and then changing facilities and not disclosing the status. And the fact that, you know, after not disclosing, she's getting these results, one which is positive today, the next which is negative. So what advice can we try to focus on this woman and try to assist Sesheke how they should actually manage this mother? Any thoughts on the same? Sorry, which hand? So Fred, I hear there's a hand. Fred, kindly please go ahead and mute yourself and go ahead.
Okay, thank you so much. This is Dr. Kawengere from Eastern Province under ICAP. I think we have a lot of adherence work to do with this lady. Primarily, we have noted through the story, the history, that the child was actually a high-risk child. So from that point of view, the mother was supposed to undergo a lot of adherence because one, she refused to take the treatment during pregnancy. She refused to start the medication on the child. She only accepted later on when probably the child had already turned positive. That is one of the consequences for refusing to adhere herself to the treatment. So I think Yetta Hospital has a lot of work to do in terms of adherence for the mother and also to make her accept so that she can disclose the status for herself.
Okay. Okay.